Hello, we are here to talk a little bit about oxygen therapy today. This is prior to us getting into the equipment, so it should be kind of interesting, hopefully. So basically, when we talk about oxygen therapy, what we're asking is, what is oxygen therapy? And basically, oxygen therapy is when we give you oxygen higher than ambient air. Remember, the amount of oxygen in air is right around approximately 21%. If we have you on 22% oxygen, you're receiving oxygen therapy, okay? So anything above the ambient air is what we're looking for at this particular point. Now, two of the things we're not going to include with this is the mechanical ventilation and hyperbaric oxygen. If you remember a little bit about HBO, that's higher than atmospheric, and we're going to talk a little bit more about that, but just to let you know, there's a lot of oxygen involved with that. And then mechanical ventilation, normally these patients are being treated a different way. That's why they're in the intensive care unit, and we'll talk about those at this particular point. So then the question is then why do we use oxygen therapy? And as you can see, it's to prevent the symptoms and manifestations of hypoxia and or hypoxemia, okay? So there are some guidelines that we all have to be familiar with. And the first one is oxygen is a drug. We've mentioned this before. We're going to mention it again. You have to have a physician's order in order to be able to prescribe oxygen for a patient. And there has to be a medical reason for using the oxygen. Sometimes we have folks who really would like to have oxygen, their spouses, maybe their significant others, or their family friends or something like that were on oxygen and they felt so much better. And, I'm feeling a little bit down. So perhaps if I took some of your oxygen, I would feel better. Doesn't work, sorry. And because it's so important, the AARC has guidelines that are based on research. These are your clinical practice guidelines. We have two different ones. One is on oxygen in the acute care setting. That's what we're going to talk a little bit more about today. And then the other one is oxygen in your nursing home or step down places, LTACs and places like that, long-term acute care centers. So one of the things we always want to remember about oxygen, and you probably remember from the very first time we talked about oxygen, it has both positive and negative effects. If you remember back in the 1800s, they had the institute that was set up in England to give everybody who needed oxygen. Lasted for a couple of years and then gradually disappeared. 1900s came around and we finally found out there's some really big negative effects that go with oxygen. And these are things we need to be aware of because we are delivering this drug to our patients. When a patient needs oxygen, though, you cannot withhold it. We have sometimes conversations with other disciplines where we're sitting there saying, Mr. Jones is on 15 liters at this particular point, and they're going, no, he can't be on 15 liters. He has COPD. He's going to stop breathing. He's going to die. And you go, well, not really. He needs to have some oxygen. We're going to monitor him. And once he starts to get better and feel better about it, we're going to start to titrate it, back off on it so that he does get much, much better. So we have to understand that, and we have to be able to tell other folks this also, okay? If you have lung issues, we can see the toxic effects fairly early. Toxic effect, though, if you don't have lung issues, we will see in a little bit longer time. So they're all related to the dose, and the dose is how much oxygen are we actually giving you, okay? And there you see, in as little as 12 hours, if you have some lung issues, we'll start to see the problems, especially if you're on 100% oxygen. So the first thing we're going to talk about then is using oxygen to treat or prevent hypoxemia. Remember, hypoxemia is a lack of oxygen in the blood. In the acute care facility, if your PaO2 is less than 60 millimeters of mercury or SaO2 less than 90% on room air, you have hypoxemia and it's documented hypoxemia. Now, we're going to talk about exceptions on occasions. If you have some folks who have COPD, really, really bad lungs and things like that, we sometimes want to keep their SATs a little bit less than 60 to keep them breathing and to keep them comfortable, okay? But this applies across the board for most of the patients that we take care of. In the subacute or home care setting, your PaO2 less than 55 millimeters of mercury or the SaO2 less than 88% of room air, that qualifies for hypoxemia. Now, neonates, and this is one of the things to keep in mind, neonates are less than 28 days or 1 month. You're going to see both of these two used. These kitties get PaO2 less than 50 or SaO2 less than 88 or a cap gas where the PaO2 is less than 40 millimeters of mercury, and they are suffering from hypoxemia. Once that neonate hits the 31st day, if you're going to use 30 days as your month, they fall into that PaO2 less than 60 or SaO2 less than 90% on room air. So you need to remember that if you have a 6-month-old child you're taking care of and their PaO2 is only 55 millimeters of mercury, that child has documented hypoxemia. There are other conditions that patients will meet in order to be able to receive home oxygen, okay? And some of these include cor pulmonale, heart failure. We see these with our patients who have COPD, CHF. We'll sometimes see those with our patients who also have COPD. Or you can see people with a high hematocrit or another one, or primary pulmonary hypertension is another one that Medicare will allow them to have oxygen, okay? And patients who just sat during ambulation or sleep in a subacute or home care setting, one of the things you may be doing if you're working in an acute care hospital is when a patient's getting ready to go home, the physician may say to you, go ahead and put them on room air. I want you to walk them so far, how many feet they decide for it, and I want you to do a pulse oximetry with them, and then I want you to make sure that you document and tell me what happens to their SpO2 at this particular point. If it's really bad, then get me an ABG and then tell me what the PaO2 is. So we have to document all this. We'll take these patients for walks. We'll use the pulse oximeter to do it. We will not only document that, but you're going to document how the patient is walking. Are they, walking like you and I normally? Are they using slower steps? If you're trying to talk to them, are they using halting speech? And where is their pulse oximeter when you get them back to their room? And then put them back on oxygen in some cases. And in some cases, you may have to do that ABG. So with hypoxemia, remember there's 5 that we talked about the last time, the 5 mechanisms. Decrease inspired O2. This is what we see in our patients who have COPD. These are people that we see that go mountain climbing, okay? A diffusion defect. One way I like to talk about that is if you have pneumonia or something like that, you have a buildup of the mucus in your lungs, you have a diffusion defect. You're not able to diffuse the gas as well before you get sick, okay? Alveolar hypoventilation. Breathing 5 to 6 times a minute is not healthy unless you happen to live in India and know how to do this. And so in these cases, we need to see what's going on with these patients at this point. Is it too much oxygen? Is there too much sedation on board? What's going on with these patients? We have to watch them. A shunt and then a reduced VQ mismatch, Remember with a shunt, it's perfusion, no ventilation. A VQ mismatch can either be decreased perfusion with a normal ventilation or decreased ventilation with a normal shunt or normal perfusion. So hypoxia, for the most part, it's decreased oxygen to the tissues. Remember, there's the 4 types. We just mentioned this. Hypoxic anemia, stagnant or circulatory is another name for that one. And then histotoxic. And so let's talk a little bit about those. So some of the causes of hypoxia, the most common one is hypoxic hypoxia. And this is what we see with our patients that have COPD. And this is what we see when you go to high altitudes. When you do see the VQ mismatches in the shunts, obstructed airways on occasions with a lot of mucus and other things, or collapsed or damaged lungs at this particular point. This is the only type of hypoxia that has a decrease in the PaO2. And what does that mean? Well, with the other ones, if you were to watch them, even do ABGs on them, you'd notice that the PaO2 is normal. But with hypoxic hypoxia, it's not. Anemic, this is a normal PaO2, but you have a reduced red blood cells, or you have a problem with your hemoglobin. Your hemoglobin could be abnormal at this particular point, unable to carry oxygen at this particular point, has a reduced binding capacity for the oxygen, whatever is going on at that particular point. You still have the normal PaO2, it's just you don't have any mechanism for delivery of that oxygen. With stagnant or circulatory hypoxia, you still also have a normal PaO2. This could be caused by shock, heart failure, blocked blood vessels. We can also get this when you're sitting. If you're sitting for a long period of time, you can end up with DVTs or deep vein thrombus. Remember, these happen in the vessels in the deeper portion of the legs. And what happens then is as you get up and you start to move around, you can sometimes release those DVTs, and then they can become traveling pulmonary emboli. And when tomorrow in the diseases, you're going to talk about a little bit with pulmonary emboli. So we can see that at that particular point. And then histotoxic hypoxia, this is another one with a normal PaO2. In this case, the cells can't use the oxygen. The cellular membrane has been changed a bit. We see this with cyanide poisoning, carbon monoxide poisoning, narcotics. People don't think about that. Formaldehyde, remember we use formaldehyde to preserve bodies, okay? And where can we find formaldehyde in our everyday lives? If you smoke, sometimes with some of your diet sodas and things like that, there's formaldehyde in them. Carpeting, if you have new carpeting in your home, there's formaldehyde in it. So there's other places that you can also get it. And then alcohol is another one that can sometimes do this. So what are the effects of hypoxia, okay? This happens when your tissue can't provide the oxygen that the patient needs. And what it does, it affects your mitochondrial functions in the cell. Remember, your mitochondria are there to produce your energy. And so if you don't have enough oxygen, you're not going to be able to make ATP. And if you can't make ATP, you don't have energy. It alters normal O2 metabolism, okay? Goes right along with that one. And it also produces some toxic metabolites that cause your damage to your cells and sometimes can cause necrosis and cellular death. So what are some of the indications for using oxygen? Well, we talked about documented hypoxemia. One is a PaO2 less than 60 millimeters of mercury or SaO2 less than 90%. There's other ones where the PaO2 or SaO2 in specific clinical situations are decreased. Sometimes we're going to talk a little bit about these. This happens when we're doing some procedures, and we know that that patient is going to have, say, for example, a bronch or something else, and we're going to be blocking the airway a little bit. We need to make sure that we put them on oxygen. Suspected hypoxia is one of those things that you look at a patient and you just go, there's a problem here. I'm not sure what the problem is, but there is a problem. We got to figure out what it is. And so what we can do is we can sometimes measure their SpO2 with our pulse oximeters. We can go ahead and assess them and then, see what's going on. We can ask them, oh, why don't you have your oxygen on? Oh, I just got out of the shower. Okay, we need to put it back on. You look a little pale. We need to make sure that you're getting the right amount of oxygen at that point. And then once we put the oxygen back on, then what we want to do is go ahead and reassess them and do that pulse oximeter and make sure that they're looking much better. So other reasons include severe trauma. If you're losing a lot of blood, you're going to end up with anemic hypoxia, and you're not going to be able to carry that oxygen around. If you're having a myocardial infarction, we need to be able to protect your heart so that we don't lose the entire heart and we can keep you alive. Sometimes short-term therapy for some people who are having some surgical procedures. If you're going to be sleeping during those procedures or, pretty well sedated, not necessarily all the way out, you're not going to be breathing as deeply and you're going to become a little hypoxic. If you have major surgeries, that's another reason that we need to put you on oxygen. There's your post-anesthesia care unit, your coronary artery bypass graft, hip replacements. We see a lot of hip replacements. Those guys need oxygen to help them heal. So then the question comes up then, you remember I told you there's people who tell you, this patient has COPD, you can't be giving them that much oxygen. Well, the first question that you have to ask then is are there any contraindications to giving oxygen to our patients? And the answer is very simply no. If a patient needs oxygen, we need to give it to them. Remember, hypoxemia kills. You got to prevent that in order to get this patient better, okay? So there are really no contraindications. And there's a few exceptions that are not listed. They're in the clinical practice guidelines you can take a look at. It has a lot to do with some of the devices, but you're still going to give the maximum amount of oxygen a patient needs to them to make sure that they're going to do well. So if we don't do this, what's going to happen, okay? Or what's going to be the effect if we give you too much, really? And here you see this is just a nice little table, a nice little chart. And if you notice on, let's see, 1, 2, 3 of them, it all ends up with death, just in case you're wondering if that really happens. But you could also see there's some cellular toxicity, effects upon the central nervous system, twitching, convulsions, different things like that. So we always have to watch our oxygen levels to see what's going on with our patients. So what are the possible precautions and complications that we can see with oxygen? Well, one of them is ventilatory depression. Ventilatory depression happens when your PaO2 is greater than or equal to 60 millimeters of mercury and you have high CO2. And if you think about this, this means we're talking about somebody who has COPD. For the most part, you may have somebody who has emphysema. Remember, that makes up COPD. And what happens, if you remember, is once the PaO2 hits 60 and starts going above it, what's going to happen is their breathing slows down. So if we had a patient who has COPD and they come into the hospital and we put them on oxygen because their sats are very low and their PaO2 is very low, once they start to get better and we start to see better results from the oxygen we gave them, then we need to look at starting to delete the amount of oxygen we're giving them. One of the questions that you see, and one of the things you'll see when you're working in the acute care facility, not so much in the subacute care facilities, is a patient comes in, you put them on 6 or 8 liters of oxygen, they have a history of COPD, they were feeling much better after you put them on. You assessed them probably about half an hour, 45 minutes later. They were feeling really, really well. However, you don't get to see them for another couple of hours. The nurse calls you and says, you need to come down here. There's something wrong. I can't wake them up. They're very lethargic. And so you go down there, and sure enough, they're not quite waking up. If you do the pulse ox, their saturation's running in the high 90s. And they're still on that same amount of oxygen that you had put them on when they came in. And so the question is what are you going to do? And the answer is you're going to turn the oxygen down to 2 liters. In some cases, depending on the protocols in the hospital, you may have to do an ABG on this patient just to see how high is their oxygen and how high is their CO2 at that particular point. This is why you need to monitor these patients. Once they start getting better, you need to start turning the oxygen back. And if the oxygen is greater than 0.5% or less or greater than 50% or 0.5, okay, we can see absorption atelectasis, oxygen toxicity, depression of the ciliary or leukocytic function at that particular point. Now remember we talked a little bit about absorption atelectasis. If your patient has mucus plugs or something going on, what happens is the plug will block the ventilation that's occurring behind it. And as a result of that, what's going to happen is the oxygen goes ahead and leaves that alveoli, and when it does, there's no gas to replace it, and then the alveoli will collapse. And so we can do that if we give our patient too much oxygen and we don't watch him. But you do not have to be on oxygen to have absorption atelectasis. With the babies, it's not the percentage of oxygen we're giving, it's the PaO2. And this is called retinopathy of prematurity, or ROP. And what we need to do is keep that PaO2 less than 80 millimeters of mercury. What happens with these children is that pressure that's in the vessels, and we're going to talk about preemies and babies that are less than 30 days old. We have to be careful because their vessels are very delicate. And so if you give them too much pressure, and this basically happens with the eyes, you'll start to rupture the vessels behind the eye. And if you rupture enough of these vessels, what happens is that you're going to detach the retina at that particular point. There's about 5 different stages of ROP, and we know 4 and 5 is definite blindness. The other ones have different stages that go with it. So when we're taking care of these children, one of the things we always have to monitor is where's their PaO2, and it has to be less than 80. And then there's also paraquat poisoning. Paraquat's one of those things that they were using to spray the marijuana plants with, and people would go out and smoke it, and they would end up with it, and they'd end up in the hospital with hypoxemia or hypoxia, and we would give them oxygen, and we cause pulmonary fibrosis at that particular point in time. Bleomycin is like a cancer-fighting drug, same thing. It has reactive oxygen radicals, and that causes a problem because it reacts with the iron at that particular point. Laser bronchoscopies are kind of interesting. There have been reported fire hazards that happen with those. Patients having their bronch done, and it's a laser, and then all of a sudden you set the airway on fire. If you're there and that happens, you need to make sure you grab some of the fluid you're giving them, the normal saline or whatever, and help put that fire out. Fire hazard, generally, because we know about smoking and fire and oxygen. And then the other thing we need to watch is bacterial contamination associated with our equipment. Number one microbe we have to be careful with is Pseudomonas. When we have water that we're using with our equipment, that water has to be watched. It needs to be emptied out, not refilled unless you clean the container in some cases. Other ones, if you take the water off of the oxygen device you have the patient on because it doesn't go with it, throw it away. You can't keep it open for 2 or 3 days and then try to put it back on. All you're going to do is reintroduce the bacteria into the patient. Okay, so we're going to talk a little bit about oxygen toxicity at this particular point. Oxygen toxicity is caused by high FiO2s, normally keeping your patient on 100% oxygen for an extended period of time. It's hard to realize it, but when we do that, it causes hypoxemia. How does it cause hypoxemia? It causes hypoxemia because what happens is that we have a lot of free radicals and other things that happen in the lungs. The lungs have already got some damage, and now we're going to make it worse. What happens is that we call the inflammatory mediators to come help with the lungs because of what's happening to them. The inflammatory mediators are your neutrophils, your cytokines, your macrophages, whatever else happens to be there at that particular point. And what they're doing is instead of taking care of the infection, they're starting to cause more infection to occur. This is where also you develop the hyaline membrane, and the hyaline membrane surrounds the interior portion of that alveoli. We go ahead, we also have problems with our type 2 cells. We have a terrible problem with those because we're going to affect them also. And so what happens is as this infection is building up, it's building up inside of the alveoli. The alveoli has now a lot of exudate in it, and there's no gas exchange taking place because of this. So how do we prevent this? We prevent this by decreasing the FiO2 to less than 100% within 24 hours if we can. 2 days is the max we want to do it if we have to. However, that doesn't apply when it comes to the intensive care unit, and we'll talk about that in 4th semester. We also want to decrease that FiO2 to less than 70% in 2 days, and then less than 50% in 5 days. If we can do that, then we can save some of those alveoli. And then we're going to talk about the free radicals. Free radicals, I think I mentioned one other time at the very beginning of therapeutics. One was the O3. There's your ozone. What happens with free radicals? Well, free radicals sit there and they start to damage the neurons that we have. And as a result of that, they start causing a lot of problems with our patients, okay? And just to show you, this is how we get hypoxia from having too much oxygen. There you see it, increased FiO2, little O2 toxicity, more shunting. We have a low PaO2. Because the PaO2 is too low, we're going to increase the FiO2. We increase the FiO2, we increase the amount of O2 toxicity, and round the circle goes. So what are some symptoms of oxygen toxicity? They occur with 2 systems. One is the central nervous system. The second one is your pulmonary system. And the central nervous system, you can see here, we have problems with the eyes, bleeding, fibrosis, muscular twitching, and seizures. Respiratory, we have normally dry cough, substernal chest pain. There's a shortness of breath, tracheal bronchitis, and if this continues, this can lead into ARDS at that particular point. And then again, absorption atelectasis, we talked a little bit about that. Too much oxygen watches the nitrogen from the lungs. There's nothing to hold the lungs open, the alveoli open, once the oxygen leaves because of some type of plugging. And as a result of that plugging, now the alveoli are going to collapse. What do? Add more oxygen. And there it is. You have to have greater pressures to keep those lungs open. There's your blocked airways, and the airways can become blocked from just mucus, okay? And they are going to collapse distal to the obstruction. You don't have to be on oxygen for this to happen. And it can be mucus plugs. It can also be breathing very shallowly, small breaths. And so if you have somebody who's breathing very tiny breaths, they're not moving that mucus around. If they're not moving that mucus around, sure enough, they're going to end up with absorption atelectasis. There's your decreased ventilatory drive. Again, it's our patients who have COPD for the most part. They have chronic hypercapnia, those high elevated CO2 levels. They could have neuromuscular disease. We sometimes forget about those patients, but they also have this happening to it. And then once you give them too much oxygen, you have a decreased rate and depth of breathing, and the patient will stop breathing at that point. There's your happy baby. ROP used to be called retrolental fibrosis, but we changed the name, thank heavens. It's much easier to say ROP. And remember, that's caused by having a PaO2 greater than 80 millimeters of mercury. You have to keep it less than that to prevent it. And it does affect the arteries in the eyes. These are the newborns, the premature babies, the low birth weight babies. After 30 days, these babies are okay. They're out of the woods, and we don't have the problems with them then. So what are some of the limitations? What are times that we think that perhaps we need to use oxygen, but there's nothing that seems to justify it? And one is hypoxia due to anemia. When you do a pulse ox on a patient who has anemia, their saturation is good. Their saturation is above 90. The problem is, though, these guys don't have the carrying capacity to carry the oxygen around. And sometimes people don't understand, let's give them a little bit more oxygen so that we can sort of flood what we have available to get some of the oxygen around. So we have to keep an eye on those patients because otherwise people have a tendency of taking them off their oxygen too quickly. Circulatory disturbances, you can't do too much for those. Sometimes, though, we do have to give them oxygen, especially when they end up with pulmonary emboli. They're going to need that to keep themselves appropriately oxygenated. There's your stagnant or circulatory hypoxia. And then when you have mechanical ventilation that's required, you can't stop and not do it. We have the high flow nasal cannula. The high flow nasal cannula is working wonders for a lot of our patients. We still have CPAP, BiPAP. We're going to talk about that also. And they do what they need to do. But if you definitely have a patient who needs mechanical ventilation and they're willing to allow it to happen, you have to give them the oxygen that goes with the mechanical ventilation. You cannot sidestep them somewhere else and then later on try to put them on mechanical ventilation. So how do we assess that you really need oxygen? Invasively, let's do an ABG. Let's take a look at your documented PaO2, documented SaO2. Non-invasive, there's your pulse oximetry. Anything less than 90% is normally an indicator that your patient needs oxygen. Observation, what does this patient look like? How are they acting? And then put it together with your clinical knowledge. If you understand how people who are hypoxic act, then you have an idea that there's something going on. An example would be you take care of Mrs. Jones. Mrs. Jones is really excited. She thinks she's going home this afternoon. She's got her oxygen on, and she said, I'm going to do better. I'm going to make sure I wear my oxygen. My son's coming in. I'm so excited. He's going to come and see me. And you go, Mrs. Jones, we'll see you before you leave, okay? And then we go back up there because we get a call from the nurse who tells us there's something going on. You need to come check her out. So you go into Mrs. Jones's room, and there she is. She's all packed. Her hair's all done. And she goes, guess what? My sweetie's on his way. You okay? Who's your sweetie? Well, he's the guy who lives a couple of doors down from where I live. He's a real sweet guy. Oh, okay. Mrs. Jones, where's your oxygen? Oh, I don't need that, sweetie. I just, I feel so good as it is right now. I'm just so excited. We're going to have a tea party. Would you like to come this afternoon? That should tell you through your observation and clinical knowledge, things are not going very well. And as a result of that, there's a problem. The patient is suffering from hypoxia and maybe hypoxemia. And then once we start you on oxygen, about 1 to 3 months after, we're going to do an ABG. This is your long-term oxygen. At this particular point, we have to document the assessment for this. After that point in time where we do that initial assessment, and sometimes you may have to do a follow-up. Most of the time, it's just a follow-up to make sure that you're doing okay. So how do we assess the outcome? Well, first of all, your PaO2, SaO2 has gotten better. It's where it needs to be at this particular point in time. Your pulse ox is reading better. It has increased PaO2. Things are looking right up there for you. Cardiac improvements. Remember, the first sign of hypoxemia is tachycardia. If you don't live with tachycardia every day, then that's probably caused by that hypoxemia that you have. And so what we're trying to find out is, let's get that heart rate down and make sure that things are working like they need to. You're finally able to remember that your son is coming to see you and that you don't live in that home where you used to live. You're now living somewhere else at this particular point. And you're no longer hyperventilating, because remember, if you have tachycardia, you have a tendency to hyperventilate. Now we've slowed your respiratory rate down and you're feeling much better. You're able to talk to us in complete sentences, and things look really, really good. And how do we monitor this? How's the patient responding? And even though we remove the oxygen, we'll also do a follow-up just to make sure that the patient's doing okay. And just depends on your hospital protocol how long you have to do that follow-up. And then we see the improvements with the cardiac, pulmonary, and neurological systems. We'll take a look at the physiological parameters. And then we'll also assess you when we start the O2 therapy within 12 hours if the FiO2 is less than 40%, within 8 hours if it's greater than 40%, and then at least once a shift. When you talk about the nursery, most of the time we have the patients on continuous pulse oximetry. And you'll also see that on the general floor on occasions with some of the patients who've had procedures done. They'll want us to keep them on a pulse oximetry to monitor them. So how do we monitor that equipment? At least once a day, go check it out, make sure it's working. More frequently if it's high flow in blenders. Okay, remember blenders we're using with the neonates and the babies. When you have artificial airways, we do it all the time. When it's heated, for sure. And if you have an unstable patient, and then with our newborns. So anybody says to you, what is the goal of O2 therapy? Decrease that cardiac workload, reverse any pulmonary vasoconstriction, which means we're going to increase the pulmonary system's less workload. We're going to improve the mental functions. There's your neurological aspect. And then we're going to decrease that work of breathing so that you're feeling much better. And if you have cyanosis, hopefully we can resolve that for you also. So when it comes to oxygen and oxygen equipment, two questions we have to ask are, how much oxygen can be delivered by the devices that we want to use? What is the FiO2 or the FiO2 range of each of these devices? Do we have to deliver a stable or fixed oxygen, or can be variable? And does it change with the patient's needs? And those are the primary questions we have to have. One of the things we're going to talk about when we talk about the equipment is, what is the FiO2 range? What are the categories of patients we can use these with? And how do we know when we either need to go back or up as far as that goes, titrate up or titrate down? And so oxygen devices, you have low flow, high flow, reservoir devices. Reservoirs are your mask, and your mask can sometimes hold a little bit of extra oxygen for you at that point. And then with the infants, we have all of theirs. And then blenders are another things that we use with our infants too. And then we talk about low flow, moderate, and then high flow. And when we talk about high flow equipment, it always has to be able to deliver more than 60% FiO2. And then we need to know, is it fixed or variable? When we're delivering oxygen, it always starts off at 100%. That's what's coming out of the flow meter. And now what we're looking at is how are we going to dilute it? What is it required to dilute it? So what we're going to look at is, do we have to meet the patient's inspiratory needs or demands and exceed them? If we do, it's going to be a fixed or stable FiO2. Is this patient fairly stable? Are they able to handle the low flow with the variable FiO2s? Or is this an unstable patient who needs something that's very consistent with them? And so you see, if it's a fixed or stable FiO2, it meets, exceeds all the patient's inspiratory demands. The FiO2 is stable under changing conditions, and these are our high flow devices. These are some of the devices that use our ports and our jets, okay? The viscous shearing and the vortices that we've talked about. And then for the variable FiO2 devices, the patient has to participate in meeting their needs at this particular point in time. The FiO2 is going to change under changing conditions. I'm going to show you on the next slide what they are. You may or may not dilute the delivered O2. Most of the time we are. Rarely do we want to deliver 100% oxygen to a patient unless we need to. And then we have our low flow or reservoir devices to be able to do that. And this is your nasal cannula. This is probably one of the most important pieces that you have. So what are some of the things that affect the FiO2 or low flow devices? We like to limit that terminology to RAFT. And what does RAFT stand for? It stands for respiratory rate. Normal respiratory rate is between 12 and 20. If you're breathing 32 times a minute, you're going to definitely affect the FiO2 we're giving you, and we may have to give you a stable or fixed FiO2 at that point. Your anatomical reservoir, that's back in the oropharynx region. You hold oxygen, build your oxygen up in that area, so then when you take your breath, you actually pull it in. The flow meter setting, you can go in there and say, I'm going to give this patient, say 28% oxygen, and you put in on 1 liter per minute, you're not delivering 28% oxygen to that patient. And so you need to make sure that when you set these up, that the flow meter is set up to deliver the right amount of oxygen and flow for that patient. In normal tidal volume, we range that between 300 to 700 mLs. If you're only doing 100, you need some help. If you're doing a whole lot more than that, you also have a much higher respiratory rate at that point. There's things that we need to do to see if we can make you better, and we have to watch the oxygen we're giving you. And there you can see a very happy patient. He has his nasal cannula on, and that's what we're going to talk about next time. Okay.